Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James and today I'm joined by Lottie Lewis, who is an Interventional Radiology Physician Associate. Welcome to the PA Podcast, Lottie.
Hi, James. Hi, thanks for having me. Yeah, thank you. Yeah, I think back in January 2021, I became the first PA in interventional radiology in the country. I think I'm no longer the only one, but yeah, fairly new to the role.
Perfect. One of the things that I wanted to get you on the show to talk about was, in a wider context, physician associates and ionising radiation. And I thought you'd be a great PA to talk to about those kind of issues and how that might change with GMC regulation coming soon.
Yeah, indeed.
Shall we start with the current situation as it stands for physician associates? Can you just clarify for anybody who might not already know, what can and can't PAs do in terms of ordering ionising radiation tests?
So at present, PAs cannot request any form of ionising radiation. So things that fall within ionising radiation are X-rays, so X-ray of anything, CT scans, any kind of fluoroscopy requests like barium swallows, anything that requires X-rays to produce the imaging, PAs cannot request at present. Other imaging such as ultrasound scans, MRI scans, which don't use ionising radiation, which can be harmful, PAs technically can request, but I think there are, it depends on local policies, local governance, which various trusts have in place.
That's the thing, isn't it? That I think varies across the country for a lot of PAs at the moment. It's down to the individual radiology department and their decision making and their policy with their X-ray machines, with their CT scanners, with their MRIs in their hospital. They set what they're happy for PAs locally to do and not do, and that might vary with the country.
That is correct. I know that in my own trust there was there's at present no formal governance around what we can and cannot order. However, some people believe that physician associates cannot order MRIs for whatever reason, but it's never been written down anywhere. So as physician associates grow and become more integrated within the health profession, more governance and kind of written structure around what we can and cannot order will be put in place.
Could you help me understand as well what IRMA means and why that's important to these sorts of topics and conversations?
Yes, so IRMA stands for Ionising Radiation Medical Exposure Regulations, which the latest one was back in 2017. These are a set of regulations that are put in place to protect patients who are undergoing kind of ionising radiation imaging. And they state that a profession requires to be regulated before you can request X-rays and ionising radiation. And therein is the problem for physician associates at present. We are not at present a regulated profession, and therefore under the IRMA regulations, we are unable to order ionising radiation.
Okay, perfect. So if we bring those two things together, so we know hopefully in the not too distant future, the General Medical Council will be the statutory regulatory body for PAs and we will become a regulated profession. What then happens, do you expect, once we become a regulated profession in terms of IRMA?
I think my expectation would to be that obviously it's not going to happen overnight. As regulation has not happened overnight, I don't think that physician associates can wake up one morning and even though we've suddenly regulated on a register, we can expect to immediately be able to order ionising radiation. I think it's something, again, that local trusts will have to kind of formulate their own guidelines and policies and governance around. And once those conversations have taken place, it will then be dispersed amongst the physician associates within that trust that they can, moving forward, can order ionising radiation. But yes, I think there will be more paperwork to come.
So obviously this is just you and me having a chat. We're not making any promises. We're not in a position of power to affect anything. It's just what we think and what we expect might happen. It might be wrong. We'll just put that disclaimer on the podcast.
Yes, of course. No insider information, don't worry.
Yeah, exactly. But I guess it might be sensible for any physician associates who are listening to this, who are working in hospital trusts or indeed in GP land and need to order these kind of tests. It might be sensible for you to find your local radiology department and maybe start engaging that conversation with the manager and saying, okay, we're expecting GMC regulation coming soon. What do you think we should be doing? Shall we get prepared so we're ready for when things are in place? Because there will be, like you say, additional paperwork and training and these kind of conversations need to be had ahead of time, don't they, for it to happen?
Yeah, most definitely. And I think, it has been a problem, I think, even for PAs within the community, from GPs having to request imaging. And then even though, we are technically allowed to order ultrasounds and MRIs, etc., there has been a pushback from the hospitals to be like, hang on a second, a doctor hasn't ordered this. And I think, there needs to be conversations ahead of time. If we're having problems already with scans that we can order, expect problems, further down the line if you haven't had those conversations prior to regulation coming into play.
Absolutely. I think that's really good advice. I can speak from my own experience, saying all it took was opening that door, having a conversation with my radiology department and just formalising at the moment what their policy is, what we can do and what we can't do for the local PAs in hospital and in our GP primary care patch as well. Everybody now knows we're all singing from the same hymn sheet, and things have been pretty smooth. You need to have that conversation to make things happen, really, don't you? Yeah,
correct.
So for those who might not know, could you explain what the process is to get an X-ray or a CT scan booked? If you're a physician associate and you need a scan booking for your patient, what's the process?
So, of course, with any kind of ionising radiation, you'd need the help of a friendly doctor who will assist you with the ordering of that scan. Of course, it's very much based on a trust relationship between you and the clinicians that you work with in terms of getting those scans ordered, and generally a good working relationship. And hopefully, if you're part of a team, that doctor knows the patient as well. So first and foremost, a doctor needs to request the scan. Let's say, for example, a CT scan is then requested. I'm sure, as it in most trusts, as it is at St George's as well, that once you order something like a CT scan, it doesn't just happen automatically. And what you would need to do is give the radiology team a call and get that scan vetted, because part of their job is making sure that the scans are clinically indicated, because otherwise we'd be ordering scans left, right and centre without putting much thought into it. And actually, there is a risk that comes with these scans, which is why IRMA is in place. There needs to be protection for patients against radiation because it causes harm. I think there was some difficulty in physician associates having to call up radiologists to get scans vetted. And I think that term vetted is quite a confusing term. And I think people were saying that physician associates cannot vet scans. And that is correct. Physician associates cannot vet scans. However, physician associates are able to have a clinical discussion with a radiology doctor who, if is in agreement with the indication for that scan, the radiology doctor can then vet the scan. And I think in some trusts there was some confusions about PAs vetting things, and actually PAs do not vet anything, but they are able to have a clinical discussion with radiology doctors who can then vet the scan.
Brilliant. Thanks for explaining all of that, Lottie. Really helpful to just understand a little bit more about IRMA and regulation and where we are at the moment. So do you want to explain to me what interventional radiology actually means? What do you do in your day job? I think
interventional radiology has always been that specialty that hide in a dark corner in the back of the hospital and nobody really knows what we do. So in essence, it is non-invasive techniques which are radiologically guided using many different modalities, either ultrasound or fluoroscopy, CT guided procedures, and they can be diagnostic or they can be therapeutic. Interventional radiology itself is growing as a specialty. We currently don't have our own admitting rights, as it were, like much other specialties, have admitting rights to bring the patients in. So patients usually come into hospital under a different team and then they get referred to us. In a nutshell, I kind of describe it as like non-invasive surgery or non-invasive diagnostic imaging, or minimally invasive, should I say. So yeah, I think that's more or less it in a nutshell.
Perfect, thank you. In my day-to-day practice, I don't find the lack of being able to order an X-ray or a CT scan that prohibitive. All it takes is a friendly doctor, registrar. Just, can I ask a favour? Would you mind? I'll just explain the patient and the presentation. Would you book that scan for me? And then it's usually fine, and I can go around and discuss and vet and approve the CT scan or whatever it might be that's needed for the patient.
Mm-hmm.
You work in interventional radiology. How do you make that work if you can't order ionising radiation?
So this is a common question that I get asked in terms of, do you not find there are massive barriers working in radiology as a physician associate? And I can thankfully say it's never been a problem. So as I work within IR, I've discovered that we don't order any of our own imaging. We get referred patients from a variety of different specialties, and whatever they want doing, obviously there's a discussion, a vetting discussion that happens, much like the radiologists don't request the scans that the specialty is requesting. We don't request the procedures that we're doing. So all procedures have been requested by a doctor and are vetted by our team. And I have no problems with being able to perform the procedures alongside the consultants and registrars. It was one thing that I certainly, was a bit cautious of when I first started, because although I'm not ordering the imaging, I am pushing the pedal and delivering the X-rays. And I thought, is that something that I'm allowed to do? So I was very cautious before I started, and I had a meeting with our lead radiation advisor of the trust just to clarify with him my position in terms of regulation and training and what I was and wasn't allowed to do. And thankfully, because I hadn't made the decision to do the procedure, as in hadn't requested the imaging, it wasn't actually a problem for myself. So pushing the pedal, as it is, wasn't a problem for me.
Oh, cool. Brilliant. So can you give us a flavour of what sort of investigations you do commonly yourself in interventional radiology, and more widely what interventional radiologists can do?
Yeah, so interventional radiology covers an absolutely huge range of specialties, and the workload is massively varied. So I can't really say there's day-to-day things that we do lots of. But we cover kind of oncology, urology, general surgery, gastro, hepatobiliary, renal, you name it, vascular. We cover lots of different things. So I suppose our list is always a bit of an eclectic mix of lots of different things, really. We do lots of lower limb angioplasties. We biopsy anything and everything. We put drains in places that most people can't get drains into. We put feeding tubes into people. We do diagnostic imaging such as nephrostograms, injecting dye into a nephrostomy to look at the urinary tract. We put difficult lines in. We've got a fantastic venous access service that do all the routine lines, but if anything's challenging, then we kind of put all the kind of dialysis lines in, things like that. So honestly, we cover lots of different things. So septic patients, we drain their if they've got a collection, we can drain that. We biopsy everything. We can do sclerotherapy of kind of venous and lymphatic malformations. The list is endless. I could keep going on and on of all the different things that we do. So I can't really say that, these are the routine things that we do, because, as I said, every day is different.
That part of the appeal to the specialty for you, is that why you chose the job? Because, like you say, if you were the very first PA to work in that sort of specialty, what drew you to it?
I think it is the kind of fast pace and the diversity. You don't really know what you're going to get on any given day. Much like any other surgical list, you have your elective things booked. But, at St George's, we're a kind of trauma centre. We have a 24/7 IR on call. So you never really know what you're going to get through the door. And your list could be sideswiped by something that comes through in through A&E. But yeah, I think that's definitely why I chose interventional radiology. You know, I had a background of A&E, which had the kind of fast pace and the diversity, which I really enjoyed. But I think the A&E kind of lifestyle, the work-life balance wasn't working for me anymore. It was a fantastic job. I enjoyed it thoroughly, but I think I just couldn't keep up the pace anymore. But it was one of those, you know, I wanted to maintain interest, diversity with lots of different specialties. So yeah, it was, and also it seemed like an exciting prospect being the first PA in interventional radiology. The scope for me was endless, and I was like, right, well, time to take on a new challenge.
Oh, brilliant. Thank you, Lottie. It does sound like a really cool job. I can't imagine that you learnt much interventional radiology as a PA student. I don't think it's even on the core curriculum. I imagine you had lots to learn in your first year. How was that learning curve?
Yeah, interventional radiology is, I don't think, anywhere featured on the matrix. So yes, I think that's the brilliant thing about being a physician associate, is that you actually never stop learning. And I think in any kind of healthcare profession, you know, the world's your oyster in terms of opportunities. And yeah, I had an awful lot to learn. I was lucky in the sense that my mother is actually an interventional neuroradiologist. So I at least had some kind of knowledge as to what interventional radiology was. But in terms of my own learning, yeah, it was a steep learning curve. In terms of being able to interpret imaging and finding out what's appropriate, what's not appropriate, I had a huge amount to learn. But thankfully, I've got really supportive supervisors and consultants who had worked with physician associates in not within interventional radiology, but within the referring specialties, and they saw how well the role worked with those specialties, and they were keen to kind of take me under their wing. And you know, they knew that it would take me some time, but yeah, I've been very, very fortunate. And I think that's also what's so brilliant about being a physician associate, is that you can learn anything and everything you want to, as long as you've got the support from your supervisor, appropriate supervision, and kind of agreed local policies in place. I mean, you could do whatever they entrust you to do, and I think that's what's so fantastic.
Yeah, I know what you mean. I really value that part of the profession as well. I hope we don't lose it. I know there's a big push for postgraduate qualifications or exams or specialty training or all those kind of things. I just hope we don't lose the flexibility that we have. I don't want to be put in a box and told you can only do this and you can only do that.
Yeah,
the brilliant part of the profession is it's flexible.
Yeah, and I think that's what I've enjoyed so much about my years so far as a PA, is that I have been able to move from trauma to A&E and now to IR, and there haven't been any kind of boundaries towards that. So yeah, I agree. No one ever made me feel as though I wasn't part of the team, you know, and I think they were just so excited to have a new member that added a bit of diversity, something a bit different, and they were keen to see what my skill set could be. And yeah, it's been fantastic. I think the only barrier it's not even really a barrier. One of the difficulties is trying to get prescribing done. You know, it's quite a consultant-led service. We do have registrars, or they're actually known as fellows within interventional radiology. There are, I think, 4 or 5 fellows, but they don't just have IR. You know, they have diagnostic responsibilities. They go off and do a 6-month secondment at a different hospital. So, you know, they're not always around. And I think sometimes the prescribing part can be difficult, but I wouldn't even say, I mean, I'm clutching at straws here by saying that that's a challenge. You know, if I have to wait 10 minutes for someone to come into a room to prescribe something, it's not even really a challenge, is it? So, yeah.
No, and that prescribing thing, I guess, is common to all of us as PAs, no matter which specialty you're in.
Precisely, exactly. It's not unique to me in IR.
What do you think the future holds for you as a physician associate? Will you grow and expand into IR? Are there new things for you to be learning?
I mean, there's always new things to be learning, no matter which specialty you're in. I think personally for me, I'd like to gain more qualifications within ultrasound training. I think ultrasound's an amazing modality. You know, it's a very transferable skill in terms of being able to move between specialties. With it, I'm, you know, extraordinarily pleased with my role within interventional radiology, and I think the kind of more confidence I build, the more trust and that I build with my supervisors and the more independence that I can gain within IR. They already trust me with a drains list on a Wednesday afternoon. And I'm fortunate enough that if I ever, am unsure, need a bit of help, or just something's a bit too challenging for me, there's always a consultant there to be able to ask and have assistance from. It's a very supported role. So yeah, I think I'm just going to kind of grow and develop my skills within interventional radiology and see where that takes me.
Might be a stupid question, forgive my ignorance. Is there a Royal College of Interventional Radiology or a faculty or a sort of governing body?
There's a society, yeah. It's called BSIR, British Society of Interventional Radiology. So they do have conferences every year. Obviously because of COVID, things have been delayed. I think they were all online. They did have a conference up in Edinburgh recently, at the tail end of last year. So, yeah, I've been very much encouraged to go to those conferences because I think they're quite keen to show me off.
Bless you. Yeah, well, I imagine if it's working well in one hospital, that it will probably grow and there'll be many more PAs popping up in IR in the years to come, I'm sure.
Yeah, hope so. I hope I can fly the flag for them.
Lottie, thank you so much for taking the time to talk us through where we are at the moment with ionising radiation and physician associates and IRMA and your job in interventional radiology. It sounds fascinating and I'm so glad you're enjoying it.
My pleasure. Thank you very much for having me.
If people have got further questions about PAs and ionising radiation or want to find out more about interventional radiology, where would be good places for them to go?
Well, I mean, I'm more than happy to be contacted if they have any specific questions about, PAs and interventional radiology. I can speak for days about what I do on a day-to-day basis. Or anything to do with interventional radiology specifically, the BSIR website's fantastic. Lots of information on there about what interventional radiology is and what we do. But yeah, if it's PA specific, more than happy to be communicated with.
Perfect, thank you. And I'll leave your contact details in the show notes so that people can find out how to get in touch with you there. Thanks so much. Yeah. And thanks to you for listening as well. I hope you found that really useful to find out more about physician associates and ionising radiation and about Lottie and her job in interventional radiology. If you're a physician associate or you've got a cool idea for another episode of the PA podcast, I'd love to hear from you. Please get in touch. I'm on social media at PA Podcast UK. It'd be great to hear from you and get you on the podcast. And I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.